I am Dr. T.S. Chandrasekhar, ACG Governor, India region, and I work from Medindia Hospital Academy, Chennai. I have we are the organizing team have managed to make up 12 webinars over a period of years, and this is what I am going to welcome you about. Information, propagating the information about the mission and mission of ACG so that all will be benefited. Over these years and the last 3-4 years, we have done 2 series of webinar, and we have seen over 9,000 delegates from all over the world who have been benefited by this webinar. And this webinar series 3 is endorsed by ACG and accredited by the Tamil Nadu Medical Council and organized by our institution, Medindia Hospital and Academy, which are affiliated to the Tamil Nadu Dr. MGR Medical University. I bring warm greetings to all the delegates from all over the world and the ambassadors for this webinar and the faculty. And this webinar goes with the tagline, name the topic, the world experts are here. Here we could confidently do that because we could line up the 12 webinars with the international faculty from USA and the national faculty from India and able moderators also. The first webinar in this series is going to start from today onwards and 7 p.m. to 9 p.m. We are going to have 2 important talks, which we already just the address to the press also, how to approach refractory IBD, best principles. And the second talk will be the Crohn's disease, which drug, when and why. These are the things. And my duty to introduce the faculty now. And who would be fortunate to have more than the president of American College of Gastroenterology to inaugurate this webinar and to deliver the first lecture, which is which we have requested him to deliver at the Medindia Oration, Professor Dr. Jonathan Lighton. He is the professor of gastroenterology and hepatology, Mayo Clinic, Arizona, United States of America. And he is the medical director of the Office of the Mayo Clinic Experience and the physician of the year, Crohn's Colitis Foundation of America Southwest Chapter. He is the associated editor of American Journal of Gastroenterology. And I would like to know more about its Occidental College, what is it going to be. And he has authored over 200 peer-reviewed articles, and his areas of interest very clearly. And this is going to be moderated by my good friend and the past governor of ACG, and he is the director of Institute of Gastroscience, Apollo Clinical Hospital, Calcutta. He is an endoscopist, and he has got a special interest in liver disease, and is the past president of SGA, the Indian Society of Endoscopy, and the Indian Society of Gastroenterology, and editor-in-chief of the Journal of Digestive Endoscopy. I welcome you, Mahesh, and Professor Jonathan.
Thank you.
And the second speaker is Dr. Vineet Ahuja. He is a professor, Department of Gastroenterology, All India Institute of Medical Sciences. He is one of the founding members and joint secretary, Colitis and Crohn's Foundation of India. And he researches spanning from the ulcer management to inflammatory bowel disease and GERD. Now he has authored and co-authored around 300 publications in peer-reviewed journals and is a luminal gastroenterology interest and IBD. Another good friend of mine is Dr. Ajit Sood. He is the professor and head of Department of Gastroenterology, Dayanand Medical College Hospital, Ludhiana. He is one of the founding members. He is a very, very important focused work in IBD. He has got over 370 scientific publications, B.C. Roy National Awardee, and his interest is IBD. So we have chosen the first topic is IBD, because of the increasing trend. This work would not have been possible without the cooperation from my colleagues, Dr. Gokul, Satya, Raja Yogesh, Prasad, and Dr. Tringana Sambandam. This time we have done 2 new things compared to our previous webinars. What we have seen the response of the webinar, we identify the leaders in various parts of the India, Dr. Chaubal, Praveen Roy, Ramesh Kumar, Srinivas Rao, Praveen Kumar, Arvind Gabi, and Girish Kumar, Mohapatra, Ashish Agarwal, Nirmaljeet, Rajiv, and Venkat Iyer as our national ambassador, who they carry the message about this webinar and ACG mission and vision to the rest of the members and the gastroenterologists. And equally, we have the international ambassadors, Dr. Vivek Sandeep, Dr. Chandramouli, Sitaram Chaudhary from various neighboring countries, Farooq Ahmad, Ajay Eva, Rajesh, and Akande, and Dr. Ishan, and Dr. Bidad. So this is, I welcome you, all of you, our ambassadors, and I welcome you, the faculty, and the delegates from all over the world. We managed to get the credit hours from Tamil Nadu Medical Council. Now, the academic partner I need to introduce you. These are the Micro Labs Limited, Micro Lab Academy, and this is about the. Now we have come to the before the starting the first session, the inaugural address and the first lecture by as oration by Dr. Jonathan Lighton. We are going to inaugurate the webinar series. May I request Professor Jonathan Lighton to touch the button, and this will immediately the inauguration will happen. Professor Jonathan.
There you go.
Thank you very much, Professor Jonathan, for inaugurating this webinar series, the third series, 12 webinars, and endorsed by ACG. ACG told me that, and you line up all the webinars and identify the faculty, confirm their faculty. So the first is on 24th April, second is May, June, July, and we have wide-ranging topic from the refractory IBD to pancreatitis, geriatric and pediatric gastroenterology, and publications we want to tell that. And we have identified the various international faculty and national faculty, Vivek Kaul and Sita Chakratia, and the Jasmine on Bajaj, and Babu Mohan, and we have lined up till March, and celiac disease by Professor Amy. She is the president-elect of ACG, and we have Dr. Nageshwar Reddy and Dr. Nicholas Sahin on Barrett's esophagus, and Dr. Sivsarin on hepatology, Douglas Rex on colonoscopy, and Neil Stolman on fecal microbiota, and Costas Kafalas on high-quality colonoscopy, and William C. on H. pylori infection. So these are the 12 webinars, and we are going to add more faculty, Indian faculty and moderators. So we will put up a good show, and we have managed to have it everything on Wednesday between 7 p.m. and 9 p.m. Indian time. Now is a time for me, with the permission of the moderators and the other faculty, the lecture session starts now. May I invite Professor Mahesh Goenka to initiate the proceedings of the first lecture. Thank you.
Thank you, Dr. T.S. Chandrasekhar, and welcome to all the faculty and the delegates. I'm so happy to be a part of this first session of Web Series 3. Whatever Dr. T.S. Chandrasekhar does is like a king. So he always does in a big show, and whatever he has presented till now and we are looking forward to, seems like that we are going to see a huge show in the coming months and years. I'm so fascinated by the list of people he has shown and the list of topic he has chosen. I'm so happy that he is now presently the governor of ACG, representing India in the ACG forum. I think he could not have chosen better people than this across the globe, one from the Western world and one from India, to be present in the first seminar. Dr. Jonathan Lighton has been a friend of ours from India. We have interacted with him many times, even in his earlier position in ACG, and he has paid a visit for the best of ACG in India, and which was a memorable visit and was the inaugural best of ACG a few years back. I think his interest in inflammatory bowel disease is well known, and we look forward to hearing him in the next half an hour and then interacting with him in the subsequent few minutes. So with that, let me welcome Professor Jonathan Lighton for initiating his talk. It's a very important topic about the management of refractory inflammatory bowel disease. Dr. Jonathan, please.
Thank you, Dr. Genka. It is really an honor to be here. And I want to thank Dr. Chandrasekhar and Dr. Genka and Dr. Sood for inviting us. I would also like to say that it's been an honor for the American College of Gastroenterology to partner with India so closely over all of these years. And as Dr. Genka said, the program for this year looks wonderful, and my congratulations to all of you and the organizers for this. So I'll go ahead and talk about the approach to difficult to treat inflammatory bowel disease. And the objectives are to define what I think are the three pillars of inflammatory bowel disease care, to describe the approach to therapeutic drug monitoring, to appraise current medical therapy for IBD, and then to determine the best approach to the refractory patient, because this has gotten very complicated. And I thought I would start with a case. This is a 37-year-old who was diagnosed with ulcerative colitis in 2016 and was previously treated with adalimumab and azathioprine, but they stopped working. And in 2017, went on infliximab, standard dose, 5 milligrams per kilogram every 8 weeks, monotherapy. And then in 2020, started having a flare. And you can see that but just before I saw her in 2020, her level was low. Infliximab level was low at 2.8. For maintenance, we like it in the 8 to 12 range. She also had antibodies of 78. And what the doctors did was just increase the frequency of the medication to every 7 weeks, which is usually not going to be effective. And then 2 years later, she still had low levels of infliximab at 2.8. The antibodies were 35. And so they then increased the frequency to every 6 weeks, which likely will not have much of an impact. And then I saw her in December 2022 on prednisone 40 milligrams a day. Her calprotectin was elevated 2490, and her CRP was elevated. And so I think that this case illustrates some of the pitfalls in the care of our inflammatory bowel disease patients, in that immunomodulators like 6-MP or methotrexate are underutilized with the anti-TNFs to decrease the chance of antibody formation. I think that therapeutic drug monitoring, TDM, is not adequately utilized. And then medications are not always maximized in an efficient manner before switching. And then finally, sometimes the symptoms or the etiology of the symptoms is not understood, and they're not always related to inflammatory bowel disease and may be more related to irritable bowel syndrome. In this patient, we considered the use of JAK inhibitors or ustekinumab or to try to salvage with anti-TNF. And because I like to conserve therapy, we increased the infliximab to 10 milligrams per kilogram every 4 weeks and added a thiopurine for immunosuppression of antibodies. And she actually did well. So with that, I think it illustrates the fact that we have to be aggressive from the start to avoid refractory disease. And the three pillars of IBD care that I'll cover are early intervention, treat to target, and tight control. And if you do this from the beginning in most of your patients, at least with moderate to severe disease, you have a much better chance of treating the disease. And so the first pillar is early intervention, particularly as it applies to Crohn's disease, because there is a window of opportunity when there is a lower inflammatory burden and there's less bowel damage where you can start therapy. And so you can see here that the ideal time to treat would be in the preclinical phase, but we don't know when that is yet. The next time to treat is in the early phase, when the inflammation is just beginning, patients are starting to have symptoms. And this is when we really can use these new medications, the biologics and small molecules, to actually modify the disease. And you want to get this done in this early Crohn's disease phase rather than waiting until the late disease where there's bowel damage, impairment of GI functioning, or even the development of dysplasia. So the earlier use of anti-TNFs like infliximab, adalimumab is associated with better outcomes. And our overall goal is to reduce bowel damage, hospitalizations, surgeries, and disability. And we know that patients who have a shorter disease duration do better overall. So the second pillar is then treat to target. And the reason we talk about this is because previous therapeutic strategies failed to alter progression, and there was a discordance between symptoms and objective measures of disease activity. So when we talk about treat to target, it's really important to have objective measures that we can follow to make sure we're making a difference. So obviously we start initial treatment, and then you want to assess your objective measures, whether it's patient-reported outcomes, mucosal healing, or even following calprotectin. And if those targets are not responding, then you have to adjust treatment. You have to either increase the drug or change to a different mechanism of action. And so we want to reassess that target periodically and continue to monitor. And if you use this treat to target approach, again, there's evidence that this can make a very big difference. And this was shown in the CALM study, which was testing the treat to target approach. And you can see that with the treat to target approach, there were the orange compared to the green columns, that there was an improvement in the primary endpoint, deep remission, and biologic remission. And so it's thought that this treat to target T2T is an effective control, because this tight control led to significantly higher rates of steroid-free remission and significant reductions in hospitalizations and deep remission as well. And then finally, the third pillar is tight control, because you need to keep a very close eye on these patients, and frequent monitoring is important. So we recommend close monitoring in the active phase, determine response to medications and stability. And in the refractory patient, those high-risk patients, we recommend what we call proactive TDM, proactive therapeutic drug monitoring, to improve endoscopic and long-term outcomes. And we look for a cause of symptoms. Is it because they're underdosed, or because they're non-responsive? Do they have an infection? Is it really IBS or irritable bowel syndrome? Or might there be bacterial overgrowth or a stricture? And then after that, in the maintenance phase, we monitor adherence to maintenance regimen and utilize biomarkers and laboratory assessments to detect relapse. And you can see that we like to use the calprotectin and the CRP. We think the calprotectin is more accurate for ulcerative colitis and colonic Crohn's disease than small bowel Crohn's disease, but it still can be used. It's probably better than the CRP, but the combined measurement of both markers is very useful and can help predict relapse in many patients. And so this shows an algorithm for tight control of the refractory patient, which I've sort of discussed. You do a baseline assessment, and then you decide on your initial therapy. But then very quickly, 2 to 4 weeks, reassess disease activity and start proactive therapeutic monitoring. In 4 to 8 weeks, reassess labs and determine if they're improving. And if they're improving, then you continue to follow up. If they're not improving, then you have to, again, test the drug levels and adjust the medication and be very aggressive in terms of this tight control. We do know that complete mucosal healing after 2 years of therapy predicts sustained steroid-free remission and clinical remission over the next 3 to 4 years. So if you're lucky enough to identify mucosal healing, you're making a big impact. Now, the IBD therapy is getting complicated. And now, as I mentioned, there are biologic and small molecules. And in terms of biologic drugs, we have the anti-TNFs, as you can see here. We have the anti-integrin molecules. like vedolizumab there that target alpha-4 beta-7. We have the IL-12, 23 and IL-23 drugs like ustekinumab and risankizumab, and now mirikizumab. And then also the new small molecules, the JAK inhibitors like tofacitinib and upadacitinib, and then finally the S1Ps, which are also small molecules. So it can be very difficult to keep this all straight. And so it's really important that those of us who treat inflammatory bowel disease and want to take a personalized approach, you have to position the IBD therapy. And I don't have the time to go through all of these boxes, but you can see that for each drug, there's an important way to use them. For example, the anti-TNFs in the orange box are best combined with immunomodulators. They're IV and sub-Q options now, and they are known for a rapid onset of action and work great for extraintestinal manifestations. On the other hand, the anti-integrins work best in anti-TNF naive. They have a low risk of immunogenicity, and IV and sub-Q forms exist. We know that the anti-IL-23/12 and IL-23s work well in someone who has previously been on an anti-TNF. There's, again, a low risk of immunogenicity. Again, they work relatively quickly. They tend to be IV and then sub-Q. They also are used for dermatologic disorders and arthritic complaints too. And then the two small molecules, the JAKs, which are oral therapy for ulcerative colitis and Crohn's disease, can be used after anti-TNF. They're known for a very rapid onset of action and high efficacy. And then the S1Ps, ozanimod, etrasimod, which again, oral therapy for ulcerative colitis, work best in TNF naive. Again, because they're small molecule, there's no immunogenicity. And so it's important to frame these different drugs and to understand how one might use them and in which patients we might use them. So the challenges historically with IBD therapies in general, as good as these medications are, a high number of patients have no initial response. That's about 30%. And as a result, remission rates are relatively low, 25 to 35%. And then of those who do respond, a significant number lose response over time, 40 to 60%. So you can tell that this is a challenging issue. And that's one of the reasons we have to monitor these patients closely and know which drugs we're going to use next if the current drug that they're on stops working. I will say that immunogenicity, as I mentioned, is not much of an issue with vedolizumab and ustekinumab, and it's not at all an issue with the small molecules like JAKs and S1Ps, but you have to really worry about it with the anti-TNFs. And so that's one of the reasons that we talk about therapeutic drug monitoring. And so the TDM implies a relationship between the drug and the outcome of the patient. Immunogenicity refers to the concept that the body's immune system can develop anti-drug antibodies, particularly to the anti-TNFs. And studies show that the higher the serum drug concentration are associated with better outcomes. And although optimal cutoff values have been proposed, it's not clear for all the medications what those drug levels are. But the point is, if you have somebody who is not doing well and has a low drug level, you're going to have a much better chance of improving their outcomes if you can increase those drug levels. And when we talk about TDM, therapy drug monitoring, we talk about reactive testing versus proactive. Reactive testing is performed in response to increased inflammatory bowel disease activity. In other words, your patient gets worse and then you check the levels. it is very supported by pivotal studies, mainly with the anti-TNF agents. The real goal is to identify ADAs or anti-drug antibodies or low drug levels. And as I've already said, data on TDM for vedolizumab and ustekinumab is limited, but there's evidence to suggest it works there well too. Now, proactive testing is a little bit more controversial, but it is proposed in patients at the completion of induction to optimize therapy and periodically during maintenance. And there's increasing evidence for anti-TNFs that it can be beneficial, especially in high risk and refractory patients, those patients that you're really concerned about. And the key benefit of doing proactive testing is to prevent anti-drug antibodies, especially in the first year. And how effective proactive is for vedolizumab and ustekinumab is less well known. But in proactive TDM, we like to use it for these patients in the orange box. Known refractory patients, any high-risk patients that you identify. There are those that are DQA105 positive, previous history of immunogenicity, hospitalized patients, those with a low albumin, perianal Crohn's, upper GI tract, or proximal small bowel disease, rapid post-op recurrence, deep ulcers, or adverse effects of therapy or family planning. And in those cases, that's where we use the drug levels to guide our therapy. And you can check it early during induction or right after induction, and then adjust your dose. If therapeutic levels remain, in other words, if they have therapeutic drug levels but persistent activity, then we need to change to a different mechanism of action. And the reason we emphasize this is that we want to aggressively follow up on our most complex patients when starting new therapy. And the way you can define somebody who is high risk is based not only on the impact of the disease on the patient, but also the inflammatory burden and the disease course. And if the inflammatory burden is high and the disease course has been aggressive, then these are the patients that you really want to make sure you follow up on. I think one of the important things is when I first started doing this, it was just me taking care of the patient with my secretary. But what's happened is because we've realized how aggressive we have to be with these patients, and because of the complexity of all the medications, we really have developed an IBD care team, which not only includes physicians, but advanced practice providers, nurses, dietitian, colorectal surgeon, psychologist, a PharmD and a PharmTech, and medical assistants. And for those sick patients, we really need this team to help manage the patient because they have to be aggressively followed up. I think it's very difficult to do it if it's just one doctor to one patient. These patients have a lot of concerns and they call in a lot. And especially if they're flaring, they need to be aggressively followed by an IBD care team. So in the approach to the patient with refractory IBD, we communicate thoroughly with the patient and the caregivers about the current situation. And then we also talk to them before they leave about the plan and the next step. And we review the patient's history very detailed, particularly our PharmD expert does that, looks at treatment failures, and then we determine whether or not the previous IBD meds were appropriately used. We also make sure that the current symptoms are due to active IBD and not related to an infection or not related to irritable bowel syndrome. And then we try to start the most appropriate agent early with close follow-up to determine not only response to steroids, but also to the medications they're on. And then we're always thinking ahead as to what agent we would use next. And when you pick an agent, as we said, they're expensive. So we factor in the cost to the patient, access and insurance related issues, because this can be fairly complicated. And then we communicate our plan with the patient, the caregiver, and their IBD care and our IBD care team. And we often, our close relationship with all of you and the American College of Gastroenterology, we do have the ACG IBD circle, but in many cases we need to use second opinions, and there are also various clinical decision support tools. But this is a workflow that we developed here at Mayo Clinic in Arizona for our early monitoring strategy, where we have a plan of how we do it with each patient. So when we see a refractory patient, we order all the meds, including the pre-biologic infectious workup. Then we follow up with a focused visit to make sure that we discuss the options. We then communicate with the IBD team, who puts in the therapy plan and gets prior authorization. And then that team then communicates with me about, what we're going to do with steroids. And then the patient usually follows up with one of us at least by week 12, if not sooner. And then we determine if there's a clinical response. And if it isn't, then we optimize therapy or change medications. And if they've had a good response, then they follow up with our advanced practice provider. And then after that, we alternate with our advanced practice providers. But I think having a workflow like this is really important to the good care of our patients. And then there is comparative efficacy studies now and network meta-analyses, plus randomized controlled trials and real-world analyses to give us an idea of where we should use these drugs. So you can see, again, in the case of ulcerative colitis, if they're biologic naive, we'll often start with vedolizumab or infliximab. We know that ustekinumab or the JAKs are very effective after anti-TNFs, and that we prefer vedo over adalimumab in anti-TNF naive. In Crohn's disease, on the other hand, particularly for the 6 patients, we'll often start with an anti-TNF with an immunomodulator like 6MP, but adalimumab and ustekinumab are very effective for induction. And now we have, risankizumab and ustekinumab in those that are anti-TNF exposed. And this is an opportunity for what we call shared decision-making with our patients, because when you're picking all these drugs, some of the decisions have to be made by the patient, whether they prefer IV versus injection, whether they're worried about safety, whether they have extraintestinal manifestations. If they have a history of lymphoma, we would avoid thiopurines. If they have arthritis, that's where we're going to consider anti-TNFs, methotrexate, the JAKs, or the IL-12/23. And again, if they have perianal involvement, we'll use an anti-TNF with an immunomodulator. So it's really important to have this understanding and then make the right decision with the patient. And, again, based on that, then you can take the high risk or refractory patient, and then once you've identified them, then decide which drugs you might use if they have ulcerative colitis, which ones you might use if they have Crohn's disease. And then, as we talked about earlier, monitor their response at least by week 12 during induction, and then proactive monitoring after that. Remember to aim for higher levels, particularly in Crohn's disease if they have perianal disease. And then, there are subtleties beyond that point. And so, I thought I'd finish up with a few examples of where we might use this. So this was a 26-year-old male with left-sided ulcerative colitis for 5 years. He was previously treated with mesalamine, then infliximab, but developed antibodies, then adalimumab and developed antibodies, and now he's in a flare with oral prednisone. And we felt our best options were vedo, ustekinumab, JAKs, or S1Ps. And because he had been previously anti-TNF exposed, we thought ustekinumab or the JAKs would be ideal. we did start ustekinumab with an infusion, 390 milligrams, and then 90 milligrams sub-Q every 8 weeks. We contacted the patient at week 2 and week 12, and we found that he had responded by week 10. I think the important thing here is to remember with anti-TNF use an immunomodulator because that will decrease the risk of antibody formation. Now, this is a patient who had moderate to severe UC on multiple biologics, a 38-year-old female with pancolitis since age 14. You can see the medicines she was previously on. She presented to us with bloody diarrhea and a high calprotectin. She was on ustekinumab every 4 weeks and budesonide. And so, the next options that we thought were TOFA, UPA, or ozanimod. We decided to use UPA, and we got baseline labs, including a lipid panel, and screened for thromboembolic risk. Started her on upadacitinib, 45 milligrams daily for 8 weeks. We rechecked her at 2 weeks, and even at 2 weeks, it works well. The patient was clinically improved. And then we rechecked the patient at 6 weeks, and then continued UPA 30 milligrams daily for maintenance. And so these small molecules have made a very big impact in patients who otherwise have failed a lot of other therapies. And then for penetrating ileocolonic Crohn's disease, this gentleman had perianal fistulizing Crohn's, was treated with infliximab with 6-MP for 3 years, but now was flaring with therapeutic drug levels and no antibodies. So we thought we had to change class. And we thought that ustekinumab or risankizumab was a good selection because vedolizumab may not be as effective for penetrating Crohn's. And we started risankizumab, 600 milligrams IV loading dose at 0, 4, and 8 weeks, and then 360 milligrams sub-Q every 8 weeks starting week 12. And this gentleman actually responded by week 8. And that's why it's so important to follow these patients carefully. So in closing, I hope I was able to communicate that early aggressive therapy for complex IBD patients is critical. Using a treat-to-target strategy with tight control, making sure that in your practice you develop workflows to follow up on the refractory patients within weeks of starting therapy. And you have to follow objective markers because symptoms don't always reflect that. Use proactive therapeutic drug monitoring when appropriate. And you really need to become familiar with the new IBD medications because it is complicated, and understand the positioning of drugs in refractory patients. And with that, I will end. Thank you very much for your attention.
Thank you, Professor Jonathan, for an excellent overview of a difficult situation. I think Dr. Chandrasekhar will have question answer after the second talk.
Yeah, after the second talk. Now I invite Professor Ajit Sur to start initiating with the second lecture with Dr. Vineet Ahuja. Ajit, welcome.
Thank you, Dr. T.S. Chandrasekhar, TSC. It's always fun and interacting with you. When you called up, you said that, are you joining? I promptly said, yes, of course, I'm there. So from refractory...
when you are... related. Okay. You please carry on.
Refractory IBD in US, we had a nice, excellent lecture from Professor Jonathan. We move on to IBD in India. And I'll say that we all see IBD more and more in our country. But thankfully, we don't have refractory IBD, a major issue so far in our country. But overall, it appears that we are not different from IBD in West, but we are a bit behind, thankfully. And we are still using more of immunomodulators, and we have experience of using anti-TNF agents. And the drugs which are available in our country are infliximab, biosimilar of adalimumab, and recently we have added anti-antagonist vedolizumab and ustekinumab. I feel that there are two main issues which we need to address as far as IBD practice in our country is concerned. That though all of us, most of us have more experience. Is it clear? Am I audible?
Yes, you are.
Ajit, can you make it the slide show? Vineet?
Yeah. I should stop sharing.
Oh, No. You continue that.
Okay. No, I was just going to introduce Vineet. Can I
Okay,
just?
right.
Yeah, carry
Okay.
on, Ajit.
Yeah, I was saying that there are two main issues which we need to address in our country. One, that we are using more of anti-TNF agents, but with the availability of anti-integrins and anti-interleukins, I think it's time to consider these two drugs also, and moderately severe Crohn's as a first-line competitor with anti-TNF agents. Second issue is that with the availability of upadacitinib in coming months in our country, I think that's going to make an impact, as Professor Jonathan mentioned, that it may have some impact on the changing treatment paradigms in our country. So for IBD in India, we have a speaker, Dr. Vineet Ahuja, whom we all know, and he's a very good friend. And he was, a few lines about him, that he was the first Indian nominated for International Organization for IBD. It's a great honor. And currently, he is the Secretary of Colitis Crohn's Foundation India. And he is spearheading the activities of IBD activities in our country. And I like to say that his article in Gut last year, 2023, on FMT aid was the second most commonly referred article, which is a great honor. So with this, whenever Dr. Vineet Ahuja speaks, the whole country, I mean, all people interested in IBD look forward to Dr. Vineet. Dr. Vineet, please.
Thank you, sir, for a very, very kind introduction. Thank you, Dr. Goenka, and thank you, Dr. Chandrasekhar. I'm really grateful to you for this wonderful invitation. Now, we have had an excellent lecture by Professor Jonathan. He has laid down the very basic tenets of managing refractory IBD. I'll be talking about Crohn's disease, which drug, when, and why. Now, let me start with an interesting tale, and I feel this tale is relevant because probably this is the theme for the first part of my talk. During World War II, the Germans built a fake wooden airfield with wooden aircraft, vehicles, and hangars in order to trick the Allies. The Royal Air Force, the Brits, knew about this secret project for months. They patiently waited for the Germans to finish and then went and dropped a single fake wooden bomb on it. So it was wood for wood. So we have wooden bombs and we have real bombs. And when it comes to IBD, we have no dearth of bombs today. We have bombs against TNF alpha, we have bombs against alpha 4 beta 7, we have bombs against IL-12, 23, all the pro-inflammatory cytokines. But the biggest question right now, or I would say the foremost question right now, is when we talk about Crohn's disease, then in which scenario to bomb and in which scenario not to bomb? That is the most pertinent question right now. And if we look at Crohn's disease, we often think about Crohn's disease in form of fistulizing disease, structuring disease, location of disease, whether it is limited to colon, or it is ileocolonic, or it is involving upper GI. But let me place before you a very simple representation of Crohn's disease in your clinic, so that in your clinics, if you can decide that when you see a patient of Crohn's disease walking in, you can decide that how you're going to treat it. So let me divide a patient of Crohn's disease into three phenotypes. One is mild Crohn's disease, second is moderate to severe or aggressive Crohn's disease, and third is difficult to treat Crohn's disease. So let's first talk about mild Crohn's disease, or where we call about, do we really require only wooden bombs for this kind of Crohn's disease? So how do we identify mild Crohn's disease? Are Crohn's disease patients treated with 5-ASAs? Are they the wooden bombs? We do see a lot of cases of terminal ileitis with aphthous ulcers. Should we bomb them or should we just observe them? So these are first three issues which I'll discuss. Mild Crohn's disease, in fact, over last 2 years, two good papers have come, and it is now defined as in terms of clinical criteria, the lab criteria, and diagnostic criteria. The clinical criteria are very simple. Somebody who is 30 to 40 years of age, not in pediatric age group, ambulatory, tolerating oral intake, no fever, no tachycardia, no weight loss, no abdominal tenderness. If you send the labs, normal hemoglobin, normal albumin. They may be slightly raised C-reactive protein. They may be slightly elevated fecal calprotectin. On testing, there is limited disease, a single segment of ball which is involved, no penetrating disease, no stricturing disease, aphthous erosions all. Why this is important? Because 20 to 30% of patients with Crohn's disease have a mild disease course. disease. And this is non-progressive. And this may not benefit from immunosuppressive therapy. And it is very important to identify this group of patients. So once you have identified this group of patients, the treatment for this group of patients is very simple. You may either induce with budesonide, 9 milligram daily for 8 weeks, not for more than 4 months. In some cases, you may give a short course of steroids or sulfasalazine for colonic Crohn's disease. If you get a response, then the question is, how do you maintain them? You'll be surprised to know that when we talk about mild Crohn's disease, the kind of phenotype which is listed out here, and if there has been induction has been induced and you get a response, the maintenance, you may not give anything. You may just observe, you may just monitor. You may monitor with clinical symptoms with the help of fecal calprotectin. At the end of 1 year, you may look for mucosal healing. There are some patients of mild Crohn's disease where you do not get a response to steroids, or there is an early relapse after steroid taper. And that is a group of patients where you start azathioprine, or you may give them methotrexate. At the same time, also look for etiologies of other symptoms. Second is use of 5-ASAs and CT. It is a classic tug of war, I would say, a tug of war between art and science of medicine. We know medicine is art and science. The art out here is the physicians treating the disease and the patients, and 5-ASAs still remain popular choice as first-line therapy in many countries, even in Crohn's disease. Not only in Asian countries where you may say resources are limited, but also in European countries, 60% of physicians end up using 5-A as the first line of therapy. Whereas when we talk about science, the guidelines recommend it, no. Meta-analysis support it, no, they don't support it. So what would be the take on 5-ASAs? Let us take the middle part. The practical tips would be, if a patient of Crohn's disease has progressive disease and is on 5-ASAs, then stop 5-ASAs. If 5-ASAs are being used in combination with other immunosuppressive therapy in a patient with Crohn's disease, then stop 5-ASAs. However, if 5-ASA is being used as monotherapy in non-progressive, mild Crohn's disease, especially colonic Crohn's, then it possibly has questionable benefit, needs to be further studied, and in general, whatever the guidelines may say, the popular choice says that you may continue. Then the third conundrum in this mild Crohn's disease is a group of patients who have ileal ulcers, aphthous ulcers, superficial ulcers, occasional deep ulcers, and many of them have a benign clinical course. You take a biopsy, the biopsy is unremarkable. So in that case, how do you decide in terms of that, whether they have a benign clinical course or not? And so there's a revised algorithm approach which we have come up with, which differentiates between non-specific and specific etiologies of chronic or terminal ileitis. A patient has terminal ileal ulcer, thickening. How do you decide whether it has a specific etiology or it has a non-specific etiology? The algorithm is very simple. It can be easily applied bedside. Patients who come for colonoscopy just for screening, they do not have any GI symptoms, and you find that they have superficial ulcers in terminal ileum, biopsy is unremarkable, exclude history of NSAID, and these patients are unlikely to have any specific etiology like TB or Crohn's. You can safely observe these patients and ask them to come back after 6 months or 1 year. However, the same patient who came for screening, who did not have any GI symptom, came up with deep ulcers in terminal ileum, even though biopsy was unremarkable. This is a group of patients which should undergo further work, as there is a chance that they may have a specific etiology like Crohn's disease or TB. If you have a patient who is undergoing colonoscopy because they have specific abdominal symptoms and you detect ulcers on terminal ileitis, again, this is a group of patients which should undergo further work. So this is the first step of this algorithm. The second step of this algorithm is that the workshop should include the complete history. Colonoscopy obviously has been done, biopsy has been done, imaging in the form of CT enterography or MR enterography should be done. And then look for 7 features overall on the base in this multimodality work: GI bleed, weight loss, anemia, deep ulcers, specific histology, long segment thickening, necrotic lymph nodes. Even if one of these features is present, that means that you're dealing with either a case of tuberculosis or Crohn's disease. Malignancy has been excluded because already you have done a biopsy. And if there is absence of all these features, then 96.5% chance that it is a non-specific etiology. And these 7 features are very easy to remember. There are 2 symptoms out here: GI bleed and weight loss, an investigation like anemia, presence of deep ulcers on colonoscopy, histology showing granulomas, and on imaging if you find long segment thickening or necrotic lymph nodes. So clearly, there's a group of Crohn's disease that is mild disease and fairly large magnitude, 20 to 30%, which may not require advanced therapy. Advanced therapy, what is advanced therapy? That is biologicals or oral small molecules. When we talk about biologicals, you know that you have TNF alpha inhibitors, which is infliximab, adalimumab, certolizumab, or golimumab, or you have lymphocyte trafficking inhibitors. Obviously, the most famous amongst them is vedolizumab, and you have IL-12, IL-23 inhibitors in form of a P40 inhibitor, that is ustekinumab. You have only a IL-23 inhibitor, which is a P19 inhibitor, that is risankizumab and mirikizumab. And then you have JAK inhibitors, of which tofacitinib is not effective in Crohn's disease, although it is JAK1, JAK2, type 2 inhibitor. But a specific JAK1 inhibitor like upadacitinib is very effective in ulcerative colitis as well as in Crohn's disease. So these are the armamentarium of bombs you have. So we have talked about mild Crohn's disease. So you know that if you identify a patient as having mild Crohn's disease, how you're going to deal with it. Now let's come to the next category, moderate to severe or aggressive Crohn's disease. The big question out here is, which I would call a red box question, that is, do all moderate to severe disease require advanced therapy, and that too right after diagnosis? Now this is a big paradigm change out here. This is a big game changer, this question out here. So let us see the answer to this question. But before that, you would like to know what should we call anything as aggressive Crohn's disease or moderate to severe Crohn's disease. Obviously, something which is not mild Crohn's disease, or even more easy would be that any stricturing disease, any fistulizing disease, or any disease which has high inflammatory burden like deep ulcerations, high CRP, hypoalbuminemia, or severe disease activity. So this group of patients, stricturing, fistulizing, or inflammatory phenotype having high CRP, decreased albumin, deep ulcerations, you will classify in the group of moderate to severe or aggressive Crohn's disease. Now let us answer this question which I posed out here in the red box. The traditional pathway of therapy in Crohn's disease has been like step-up therapy. You move from sulfasalazine to prednisolone to azathioprine biologics, and that is in patients who have a low risk of progression, elderly disease, inflammatory phenotype, non-structuring, non-penetrating pulmonary disease. And we have learned that the top-down pathway is applicable in aggressive disease, younger age less than 40 years, complex perianal fistulae or stricturing penetrating disease, or extensive small bowel disease or upper GI disease. Why did this algorithm come up? This algorithm came up because Crohn's disease is progressive. You want to stop the progression of the disease. So it was felt that if you start advanced therapy, that is top-down therapy, somewhere out here, the patient has an aggressive disease, you would be able to arrest the progression of the disease. The question which we are asking now is that if you start advanced therapy out here, when the disease has been diagnosed, when it is not even non-stricturing or non-fistulizing, will it be useful or not? Well, we find that there were a lot of smoke signals coming up, even before I would say the fire came. The smoke signals which are coming up were in form of analysis, retrospective, prospective. For example, this study looked at anti-TNF initiation within 2 years of diagnosis and showed that it benefited in Crohn's disease, whereas the same benefit in terms of lower healthcare utilization was not seen in patients with Crohn's disease. This is for anti-TNF inhibitors. Similarly, this study did the same exercise for vedolizumab and showed that in Crohn's disease cases, within less than 2 years of disease onset, if you give vedolizumab, there were higher chances of achieving a complete response. But the same effect was not seen in patients with ulcerative colitis. Another meta-analysis, which now combined all the biological agents and again came up with the same conclusion, that relationships between short disease duration at type of starting biologics and better outcomes was found in Crohn's disease, but not in ulcerative colitis. Fine, they are all smoke signals. You need a transformative study out here, a very good randomized controlled trial, so as to get convinced that you want to start early on in the disease with the top-down therapy, and comes up with this very recent trial in Lancet Gastroenterology, May 2024, which is known as the PROFILE study, which actually looked at biomarkers, but also at the same time looked at top-down versus accelerated step-up treatment strategies for newly diagnosed Crohn's disease. What did it do? It picked up patients with active Crohn's disease and also newly diagnosed Crohn's disease. 2 weeks of steroid induction were given to all the patients, subsequently randomized into accelerated step up or top down. When we say accelerated step up, it means that you taper the steroids. If there's a flare, add steroids and immunomodulators. If there is second flare, then you add infliximab. Top down is straight away start infliximab and immunomodulators. If there's a flare, then you may add steroids. Look at the patient profile. The huge number of patients, 193 in each group, randomized. The patient profile is stunning. Most of the patients, 85% of patients were B1, inflammatory phenotype, which goes against the natural logic by which we treat Crohn's disease patients. Our logic has been that B2 and B3 you would like to do top-down therapy. B1 inflammatory phenotype, you would not like to give top-down therapy. Here, 85 to 88% of patients had inflammatory phenotype. Second interesting thing out here, most of these patients were randomized within 1 month of diagnosis. Median time for diagnosis to enrollment was 14 days. There was 9 fresh cases of Crohn's disease and straight away given top-down therapy. And the results were spectacular. The results are game-changing. The main endpoint, primary outcome measure was sustained steroid-free remission. You find a whooping difference, a difference of 64 percentage points in patients who were given top-down therapy versus patients who were given accelerated step-down therapy. Secondary outcome measures like endoscopic remission, again a difference of 23% in favor of top-down therapy. In fact, most of the secondary outcome measures were significantly better in patients with top-down therapy as compared to step-up therapy. What about adverse effects? You feel that adverse effects would occur more with top-down therapy? No, it was not seen. Adverse effects were not more with top-down therapy. So the implication of all these available evidence is something, again, which is a little bit mind-boggling, but at the same time, possibly there is a lot of substance out here that is top-down treatment with combination infliximab and immunomodulator should be adopted as the standard of care for most patients with newly diagnosed active Crohn's disease. And this was the conclusion of this randomized controlled trial. So where we talked about the diagram, where we talking about starting advanced therapy based on the concept of top-down therapy when the disease is aggressive, you find that you can start advanced therapy even if it is not mild CD, just it has to be moderate to severe CD, and that too at the disease onset. Now let me come to the second part of the talk. Now this is the bridge over River Chenab. This is the highest railroad bridge which has in the world, and it has been built in India. It has been built over the last 5-10 years. This is in the state of Jammu and Kashmir. Obviously, it's a very, very challenging bridge to build. You can see the clouds are underneath the bridge. And this is the kind of bridge we would like to make for our IBD patients because they also have a very challenging life all through, and you want to help them through. So what are the kind of pillars you would like out there if you were to build this bridge? We have already talked about advanced therapy, how early to start. We would like to know what should be the first agent, how to sequence advanced therapy, when loss of response, when to use combination therapy. So let's start with first 2 pillars, which should be the first agent and how to sequence advanced therapy. For any therapy, you have 3 key keystones. It should be safe, it should be effective. There's no point it being safe and not being effective. It should be safe, effective, and also for a country like India, especially, it should be low cost. When we look at safety signals, we find that vedolizumab and ustekinumab are most safe. They're much safer than anti-TNF, and upadacitinib. They have the same kind of safety signal in having adverse reaction profile being there. When we talk about something which is a combination of effective and low cost in the setting of Crohn's disease, it would be upadacitinib. For ulcerative colitis, obviously, it is tofacitinib, but for Crohn's disease, it would be upadacitinib. When we talk about something being effective and safe for Crohn's disease, then it would be ustekinumab. When we're talking about something which is effective, but may not necessarily be safe, may not necessarily have low cost, that is the anti-TNF inhibitors like infliximab and adalimumab. So this is the basic philosophy with which we move forward. Then we come to data, and that is network meta-analysis. And this is a network meta-analysis of patients of Crohn's disease who were bio-naive. Bio-naive means they had not been given any kind of biological therapy, and it was seen that the best responses were seen with infliximab along with azathioprine or adalimumab. So for Crohn's disease patients, they will be the preferred first-line therapy for induction of clinical remission. Next, when we talk about bio-exposed Crohn's disease, bio-exposed is patients who have been given biological therapy. So what is the problem out here? Obviously, out here, the chances of success decrease. So here, what would be the first line therapy? If there's a loss of response to a infliximab, particularly a secondary loss of response, not a primary non-response, then adalimumab can be tried, or otherwise rasanicuzumab may be tried, or ustekinumab may be tried, and they may be the preferred second line for induction of remission. We can also view it in three points. One is that the patient may be risk averse. Second is the patient has a severe disease. If the patient is risk averse, like there are prior serious infections, prior malignancy, advanced age, multiple comorbidities, then in discussion with the patient out here, the first line therapy for Crohn's disease, if you're positioning, would be ustekinumab or vedolizumab. Moderate disease, you give vedolizumab. Severe disease, you would like to give ustekinumab. Second line therapy, if it fails, you have to go back to anti-TNF inhibitors along with azathioprine. However, if the patient has a severe disease, you are more interested in decreasing inflammation as fast as possible. There's a high inflammatory burden and it is having a significant impact on quality of life. Therefore, Crohn's disease, the first line therapy would be infliximab or adalimumab, along with azathioprine, or you can give ustekinumab as a monotherapy. Second line of therapy would be ustekinumab out here, or upadacitinib, or rasanicuzumab, whenever they are available. This is the most simplified diagram we can come up in terms of positioning of therapies. Then another is, if you talk about which drug, first line, when, why, and if you quickly go through the table, it will give us an overview of different situations. High inflammatory burden, deep ulcerations, high CRP, hypoalbuminemia, anti-TNF or upadacitinib because they have a fast onset of action. You want to decrease the inflammatory burden fast. The patient cannot wait, the physician cannot wait. Age more than 60, 65 years, other risk factors for severe infections, vedolizumab or ustekinumab because there's a low risk of serious infection with these drugs. Perianal disease, infliximab. Adalimumab will be second line therapy because the best RCT data is available for infliximab. Prevention of post-operative recurrence, you can use anti-TNF or vedolizumab because RCT data is available for both of them. Psoriasis or psoriatic arthritis, anti-TNF or ustekinumab because both target bowel and skin inflammation. Axial spondyloarthritis, anti-TNF or JAK inhibitors because both target bowel and axial inflammation. Preconception and pregnancy, anti-TNF has the greatest experience, but vedolizumab or ustekinumab can also be tried because all three of them do not cross placenta during the first trimester of pregnancy. Coming back to our bridge, the bridge is actually really very high. It is 35 meters higher than Eiffel Towers. And what we have to make is what happens when there's a loss of response, when to use combination therapy, when to opt for surgery as the first line of therapy. So primary non-response occurs in 20 to 30% of patients. At the same time, do not be in a hurry to stop biologicals or oral small molecules within 2 to 3 weeks if the patient is not responding unless until the patient is having a very severe disease. This is a mistake which often we make, that within 4 weeks one would stop and move over to the next stage, and don't be in a hurry. There's a time to assess primary non-response, which ranges for 12 to 14 weeks for most biological. And if there's a secondary loss of response, that is a patient has initially benefited and then lost response, then you may like to do therapeutic drug monitoring, which Professor Jonathan has talked about in detail. Adjunct therapy, azathioprine or methotrexate, low dose azathioprine or low dose methotrexate. With infliximab, definitely in the first stage you would like to give. Maybe after that you can stop. Adalimumab, yes, probably you would also like to give for 6 months to 1 year. With vedolizumab and ustekinumab, you generally do not give adjunct therapy. However, there's some recent data emerging which says that particularly in Crohn's disease, vedolizumab in refractory cases may be useful. We have a patient on vedolizumab not doing well. Would adding azathioprine help? Yes, probably it may help. Ustekinumab, again, if there's a loss of response, would it help? Yes, it will help. Why do I say so? Because the initial pharmacokinetic studies suggested you don't need to add adjunct therapy. There are no antibodies being formed, or it's a percentage of antibody formation is just 1 to 3%. Post-hoc analysis also did not support it. But the real world target trial emulation clearly showed that combination therapy with immunomodulators, particularly in refractory cases, and that to patients with Crohn's disease, would be useful for vedolizumab or ustekinumab. Surgery, can it be used as first-line therapy in certain patients of Crohn's disease? Now, this is again a revolutionary concept for some, I would say, physicians as well as for patients, because patients, when they say they have Crohn's disease and you say, okay, just go in for surgery, they're not willing to accept it. In which scenario would you like to advocate that? Limited terminal ileal disease, less than 40 centimeters of ileum involved. Now, there was a very nice RCT which was done. Non-stretching terminal ileal disease, failure to respond to steroids and thiopurines. Obviously, the next choice is biological. So the question is, can surgery like laparoscopic ileal resection offer good short-term and long-term results? Came up two studies, the LYRIC study and subsequently its follow-up. So that was the first RCT of surgery versus infliximab in ileocecal disease, which at 1 year follow-up showed that surgery was cost-effective, quality of life was similar to infliximab, but subsequent 5-year follow-up showed that resection was, the patients who underwent resection, they had a much better quality of life and only 1/4 of them required biologicals in the long run. So the implication is that if there's a limited segment involvement, ileal area, uncomplicated terminal ileitis, then resection is a valid treatment option which compares very favorably with anti-TNF. The recent PREDICT study which came out. The PREDICT study is population-based cohort study from which looked at Danish population, which looked at early ileocecal resection for Crohn's disease and found that patients who had earlier ileocecal resection, when compared with patients who underwent anti-TNF therapy, the patients who underwent ileocecal resection, they had much lower risk of long-term adverse outcomes, and 50% of them did not require any treatment at 5 years. When you talk about this kind of Crohn's disease, only biologics are not going to help. And obviously, out here, I'm not going to talk it in detail, but this is something which is very much required. What is it? This is holistic management. Holistic management means nutrition. Diet is a very important component out here. Mental health, bone health, vaccination. Then things like this, structuring Crohn's disease, if it is a fibrotic stricture, biologicals are not going to help. Surgery is going to help. If it is an inflammatory stricture, their biologics are going to help. Then a nugget about perianal fistulizing Crohn's disease. The principle out here is that you have to treat both infection and inflammation. Only treating inflammation with the help of biological is not going to help. How do you treat infection? With the help of antibiotics. You may drain perianal abscess if present and always put a ceton thread, a loose ceton thread. Inflammation, you would like to give top-down therapy with the help of biologics and add azathioprine out here. Which one of them you give, which one of them you don't give? You give all of them. If you give all of them, your chances of succeeding are very good. Finally, we come to the last tenet out here. When to escalate? When do you decide that you're going to de-escalate? Excellent trial came up last year. Now, this trial has two facets. It's like half glass full, half glass empty. It's like yin and yang. The SPARE trial, which looked at patients with Crohn's disease who are on combination therapy, infliximab and immunosuppressant. So they randomized them into 3 arms. Now, these patients were on steroid-free remission for more than 6 months. They were treated with infliximab and immunosuppressant like azathioprine or methotrexate. So in one arm, they said continue both of them. Second arm, they said discontinue infliximab, continue immunosuppressant. Third arm, discontinue the immunosuppressant, but continue infliximab. So the question is, which one of them is going to be superior in terms of, or where the relapse rates are going to be lower? At 2 years, the relapse rates was seen. That was a primary end. And what was seen is that when you discontinued infliximab and continued azathioprine, the relapse rates are much higher compared to the arm where you continued infliximab but stopped azathioprine. So the conclusion of this study was that probably it makes more sense in continuing infliximab and stopping azathioprine. If you look at the second co-primary endpoint of this trial, it showed that the mean time in remission in the 3 arms over 2 years was same, around 684 to 700 days. It was similar. So if actually you ponder over this trial and consider it from the Indian aspect, you find that on stopping infliximab, yes, more patients relapse, 36% relapse. But at the same time, it tells you for 2 years, 2/3 of the patient did not relapse. There was a drug holiday for 2/3 of the patients. There was an economic major boom for 2/3 of patients who did not have to take infliximab. Secondly, even if they relapse, it was seen that 90% of patients who relapsed, they gained remission on restarting infliximab. The response was recaptured. So what's the problem out here? You can always look at this trial from this point of view. So if you look at general treatment cycle biologicals and the principles, anti-TNF discontinuation, the risk of relapse is around, let us say, 40% at 1 year or 50% at 2 years. For vedolizumab and ustekinumab, we do not know the risk of relapse if they're stopped once a patient is in remission. The best predictor of disease relapse is if there's a residual disease activity. And so shared decision making is very important. And you need to monitor actively in the first year after stopping, because that is a chance when the relapse will be maximum. So you do a fecal calprotectin 3 to 6 months. And retreatment with the same biological is safe and effective. Exit therapy may not be advisable in pediatric Crohn's disease. Now, another thing is biologicals versus azathromycin. We're talking about biologicals. What about azathromycin? Obviously, in this picture, I don't need to tell you who is the biological out there, the menacing biological, and who is the teary-eyed azathromycin. Obviously, biologicals are pushing azathromycin out of the scene. Can we push as a biologicals? Can biologicals put azathromycin out the scene? Yes, in an ideal world, yes, but not in areas which are resource strapped. And there is definitely data from India. For example, this paper from North India shows that thiopurines have sustained long-term remission in patients with IBD. For example, in Crohn's disease, at 5 years, 68% of patients were still continuing azathioprine, whom they were initially started, and at 10 years, 61% of patients were still continuing thiopurines when they were initially started. So obviously, in some patients, thiopurines do good. Secondly, what about side effects? Often thought that thiopurines lead to a lot of lymphomas. Yes, they do lead to lymphomas, but the risk obviously may be overstated because, again, if you looked at this North Indian cohort, we find that there were 250 patients who were on more than 5 years of thiopurine, 68 patients more than 10 years of thiopurine. There was no patient developed lymphoma. So the risk is very much there, but at the same time, may be a little bit overstated. Now, this is long-term outcome in perianal fistulizing Crohn's disease. Again, in a resource-limited setting like India, the patients out here, 1/3 of the patients, they received immunomodulators, and half of them, because obviously they could not afford biologics, and half of them maintained a clinical response for a median follow-up of 4 years. Excellent. So obviously a subset of patients with perianal CD, where obviously one would think that azathioprine should never be considered as monotherapy out there, they do respond to immunomodulators. So when your back is against the wall, when the resources are strapped, or when there's a patient preference, they don't want to take biologics, azathioprine can be. Finally, we come to the third set, the difficult to treat Crohn's disease. Difficult to treat Crohn's disease has recently been defined by a group of experts, and I'll pick up 3 definitions for Crohn's disease out here. One is failure of biologics and advanced small molecules with at least 2 different mechanisms of action. That is one anti-TNF and let's say vedolizumab, anti-TNF and upadacitinib, or anti-TNF and ustekinumab. Then you would say it is difficult to treat, not that if only there's only one biological failure. If there has been surgery in Crohn's disease, the recurrence has occurred twice. There have been 2 intestinal resections, 2 surgeries have occurred in a patient with Crohn's disease, and still there is post-operative recurrence. That is difficult to treat Crohn's disease. Complex perianal disease, that is difficult to treat Crohn's disease. So the panel of experts which laid down the definitions for Crohn's disease, these are the 3 main definitions for difficult to treat Crohn's disease. Difficult to treat Crohn's disease obviously is that group where you go for advanced combination therapy. Here we are not talking of combination therapy, that is infliximab and azathioprine, but advanced combination therapy, ACT, that is combining 2 agents, combining anti-TNF with vedolizumab or ustekinumab, or vedolizumab with anti-TNF, ustekinumab, etc. Right?
Professor, we need
Just 2
5
minutes.
more minutes. Okay. 5 more minutes.
Okay, sir. Thank you. So now you do have other therapies coming up. This is an abstract from last year in UEG, which showed that risankizumab, we talked about being a P19 inhibitor, which blocks only IL-23, versus ustekinumab, which is an IL-12/23 inhibitor. All these patients were one who had failed one anti-TNF therapy. And when they were randomized, it was seen that risankizumab was non-inferior to ustekinumab when it came to clinical remission, and was much superior when it came to endoscopic remission at week 48. And obviously, again, a very large RCTs out here showing, yes, there is hope in terms of when agency. Recent 2 papers on upadacitinib, which show that in Crohn's disease, upadacitinib achieves clinical and endoscopic outcomes in Crohn's disease, regardless of prior biological failure status. Even if the patient has failed biologics, still upadacitinib has a high chance of working. And not only that, it works fast. It reduces Crohn's disease symptoms within the first week of induction therapy, and that too in patients who have had prior biological failure. So difficult to treat patients, as I have told you the definition, obviously in terms of treatment, we do have a lot of choices which are coming. So if I would summarize and make up the algorithm, I would view Crohn's disease when it comes to treatment in just 3 simple subsets. Why? Because it is much easier to treat them. I would like to identify a patient walking into the OPD whether he has mild Crohn's disease, moderate to severe or aggressive Crohn's disease, or difficult to treat Crohn's disease. If it is mild Crohn's disease, how would I identify? Patient is 30 or more than 30, 40 years of age, ambulatory, no fever, tachycardia, weight loss, normal hemoglobin, albumin, slightly raised CRP, slightly raised fecal calprotectin, limited disease, single segment involvement, non-penetrating, non-stricting, or maybe having abscess ulcers. How to treat out there? Induce remission with the help of budesonide, and you can use it up to 4 months. Or you use colonic disease, give sulfasalazine, and subsequently for maintenance, you may not give anything at all. Just watch them carefully what is happening out there. Or you may individualize maintenance for some patients with azathioprine or methotrexate. So mild disease may not require advanced therapy. So you have to identify it is very, very important. Second is moderate to severe or aggressive Crohn's disease. How do you identify them? Those who may be just inflammatory phenotype, but at the same time have a high inflammatory burden, deep ulcerations, high CRP, hypoalbuminemia, or severe disease, structuring disease, fistulizing. How do you treat them? Well, actually, if you look at the evidence is pointing towards in this direction. This is where the world is moving towards, whatever we may say. And that is for newly diagnosed active Crohn's disease patients, even whether they are structuring, visualizing, or even inflammatory with the high inflammatory burden, top-down therapy may be beneficial for these patients. The same signal is not true for patients with ulcerative colitis. In the same breath, I would say that in resource-starved countries, it is not that we should put our heads on, because many of these patients also do respond to azathioprine. Finally, difficult to treat Crohn's disease, identify with the help of whether there have been 2 failures to advanced therapy, or 2 surgeries and still a postoperative recurrence, or a complex perianal fistula. And here you require advanced combination therapy in many cases, like 2 biologics or biological plus oral small molecule. You require surgical resection in many of these cases, so you have to have a multidisciplinary approach. Now, the bridge over the river Chenab has been completed. This is one of the highest railroad bridges in the world. It's an engineering marvel, so it should be operational within next 2 to 3 months. And look at the magnificent, fabulous photographs of this bridge. And similarly, I believe the IBD community over the world, in terms of the caregiver community over the world, is also coming up in terms of completing their bridges. And we do have pertinent answers to many of these pertinent questions. And that advanced therapy, as I told you, early to start, early in moderate to severe Crohn's disease, which should be the first agent. If we talk of efficacy, then it is anti-TNF or OPA. If it is safety, then more than ustekinumab and vedolizumab. Ustekinumab is efficacious also, but it is slightly slower acting. How to sequence advanced therapy depending on the clinical situation. There is no biomarker to guide as yet. Can you use azathioprine as monotherapy? Yes, in resource-low situations and patient preferences there. When to use combination therapy and anti-TNF and azathioprine initial 1. When to opt for surgery? Again, game changer out here, that in limited allele disease, first-line therapy can be surgery, need not be biological out there. When to de-escalate? Every case where there's clinical and endoscopic remission and has had not a very aggressive past, you can think about de-escalate. Thank you so much for your attention. Thank you, everyone.
Thank you, Vineet. Wonderful, excellent. Really enjoyed your talk. I'm sure there must be many questions for both the speakers. And over to Dr. TSC for the questions and answers.
Okay, right.
So, TSC, there are lots of questions in the chat box as well.
Yeah. What I'm going to do is, Mahesh, you have would have received a question to
Yes.
select some important, pertinent questions.
So, what I would say is that if we answer all the questions,
That will
we will
be
pass the midnight, because
okay,
I can
right.
see at least 25 questions in front of me which has been passed on. So I would only request the speakers as well as the expert. We have Dr. Ajit Sood.
Before you take up question, Mahesh, I have a very pleasant task to request you to join all of you to present this Mid India Oration Award to Professor Jonathan Lighton. And this
Sure.
is, can I just finish in a minute?
Yeah,
The
sure.
Mid India Oration Award is a prestigious, started in the year 2006, and we have given to 16 eminent stalwarts in the field of gastroenterology. You see that Samir Shah, David Greenwald, Douglas Rex, and Sunanda Kane, and Nagesh Reddy, Dongwan Seo, and all these people have received it. Christopher Coe, Philip Stew, and Jack De Beer, and the SK Acharya, Sarin. And so we have a pleasant task to present this award. Now I will have 1 minute. I will present it virtually. Please, all of you join with me.
Thank you very much. Beautiful.
I'll just present it to you virtually, and I request Magesh and other people to join me.
I told you nobody can match TSC.
You know,
This
wow.
is, I want my colleagues to be also to come on the screen, my colleagues. And this is the Medindia Oration Award 2024, the Gokul. And yeah, okay.
I
And
you
Thank you very
carry
much.
virtually with garland the medal. Professor Jonathan Lighton.
Wow.
That's a wonderful medal. It's really nice.
Love it.
Pure gold.
Thank you.
That will be
Yeah.
virtually presented now, will be shipped to you, Professor. So this is the Medindia Oration Award 2024. Thank you very much.
Thank you.
Now, Magesh and Ajit, you take up the questions. And Ajit, you don't have WhatsApp, so I will read it the question to you. And Magesh, you take a few important questions to.
Yeah, I would say that as I mentioned, there are many questions. They may not be in a particular manner that agenda we are following, but I just picked up the few of them. The first question, and they may be addressed by any of the two speakers as well as by Dr. Ajit Sood, who is around, a very experienced person. So the first question is, and Ajit has excellent work on this, can tofacitinib be given in patients who have not received NTTNF drugs? I understand that most of the guidelines talks about tofacitinib in severe ulcerative colitis to be given only when NTTNF fails, but we are also aware of the great work done by Ajit Sood and published recently, where he has given our alternative choice. Before Ajit takes up, can we ask Dr. Jonathan and Dr. Vineet Ahuja before Ajit talks about his paper? Jonathan.
Yeah, thank you. So at this point in the United States, we don't use it. We can't use it before giving an anti-TNF because the insurance companies won't pay for it. But one of the reasons that they recommended that was because there was a concern about cardiac events. But this concern appears to be mainly in rheumatology patients over the age of 55. And actually, when you look at the data, TOFA in inflammatory bowel disease patients is very safe. So I think it certainly could be used first line, but at this point, we're not doing it because of the FDA rules.
Vineet, you want to say something before we ask Ajit?
I think the thing is very clear. If TOFA was as expensive as in USA, nobody would have used it before anti-TNF therapy. It is availability, cost, efficacy, safety. The cost, but anything which is low cost and efficacious, people would just run for it. It is a popular choice, even if science may support it or not.
Ajit.
Yeah, like I think Vineet showed a slide, it's science and art. Now, the issues in our country, as I said that from Jonathan's talk of refractory IBD, we move on to IBD in India. So there is a difference. What we have in India is a big chunk of patients who can't afford biologics. And if you see that according to the guidelines, the anti-TNF are to be used first, but majority of the patients, they just can't afford biologics. So what is the choice? So that's why Jackie's TOFA has been found to be a fairly good drug. And I will mention that we have now a sizable experience of using TOFA. We didn't come across many patients with the MACE. And as it is, as the study is shown, as Jonathan mentioned, that the study trial which showed that TOFA has a MACE as a major adverse effect for patients with rheumatoid arthritis, and the age was more than 50. And in addition, all these patients had at least one cardiovascular risk factor. And IBD patients being a younger population, we do have patients reporting side effects, but not major side effects like MACE. So we are fairly okay with use of TOFA for ulcerative colitis for a group of patients who can't afford biologics.
So the next question is about fecal microbiota transplantation. I think none of you talked much about it, but we do hear many times that fecal microbiota transplantation can be one option in difficult to treat situations. Vineet.
Data for Crohn's disease is not there. So for Crohn's disease, I don't think we'll talk about FMT. For ulcerative colitis, it is there. But my take on it is that early on in the disease, if you treat with fecal microbiota transplantation, it may help. When the disease becomes refractory, at that time, changing the microbiome would be helpful, but would not be transformative.
Magesh, we have the opinion that for refractory ulcerative colitis, the FMT useful. No, recently and we had a conference in the endocrine. They said very clearly that FMT useful for the moderate or mild to severe disease in FMT.
So the other question, yeah, Ajit, you want to add?
It's always as an add-on therapy. Nobody has used FMT as a standalone therapy, and we have to keep it in mind that we have to combine it with 5-ASA or immunosuppressive agents. And I think the nice article by Vineet, which I mentioned that in the gut, I mean, there it was FMT along with diet. And it's very, very important to keep it in mind that until unless we control a patient's diet, FMT may not really work.
So the other question is that a resource limited country like us, do we have a role for tacrolimus in refractory cases? If tofacitinib particularly cannot be given, do we have a role for tacrolimus? Vineet, you want to take up, or Dr.
So
Jonathan?
yes. So tacrolimus is useful definitely for both ulcerative colitis and Crohn's disease. The only thing is that their responses generally loses response after 3 to 6 months or something like that. So that is why azathioprine and methotrexate, if one gets a response and the persistence of that of using that drug is much higher, sustenance is much higher. So tacrolimus can be used if azathioprine is not working or methotrexate is not working in Crohn's disease.
So Vineet, when we talk about these two drugs, tacrolimus, the methotrexate and azathioprine, we always talk about azathioprine or methotrexate. Is there a situation where you'll prefer azathioprine over methotrexate or methotrexate?
All situations, sir, that we prefer azathioprine over methotrexate in Crohn's disease. In ulcerative colitis, methotrexate does not work. In Crohn's disease, we prefer azathioprine over methotrexate. It's only in situations where patient is intolerant to azathioprine or develops adverse reactions to azathioprine, we switch over to methotrexate. And the reason for that is the data for azathioprine is much stronger.
So do you do in your patient with azathioprine, will you do a genetic study and
Ideally, you would like to do NUDT 15 polymorphism for sure. If not, if we have more resources than NUDT 15 plus TPMT. However, if you do not have these two resources, you can safely step up the drug very gradually while monitoring CBC. Because even if you do polymorphism, then you find them to be wild type, still an occasional patient may still develop myelotoxicity.
Dr. Jonathan, you talked about CRP and fecal calprotectin as a marker. How frequently will you like to do them? 3 monthly, 6 monthly, and in different situations?
Yeah, I think the if you can use the C-reactive protein if you know that correlates with disease flares in the patient. Many patients don't increase their CRP, and therefore it's not useful. But calprotectin is very useful. And I think that if the patient is a high-risk patient, then we'll often check it every 6 months or so to monitor it. If they're stable, it may be once a year. But we do have evidence that, a rise in calprotectin can predict relapse. So I think it's very useful to use, particularly if you're going to de-escalate therapy or you have someone that you're concerned about. Calprotectin is a great way to follow it.
Vineet, do you think we need to really be very excited about risankizumab being available in India? Do you see a huge positioning of this molecule?
More excited about upadacitinib because the cost would be also low if it is generically produced. The Risankizumab would be used, it will add to the armamentarium that all these drugs are going to get sequenced. All of one patient over 5 to 7 years would end up using 2 or 3 of these drugs. So you will have more choices to sequence.
Ajit, what is your practice for vaccination in patients with IBD? Do you routinely ask for it? And if yes, because there are too many things to be done and we have to look at the cost effectiveness as well. So what is your practice usually for vaccination?
I think with the growing number of patients with moderate to severe disease and more number of patients requiring immunomodulators and immunosuppressive agents, it's time we should start vaccinating all our patients. I admit at the moment we are not really vaccinating as per the recommendations, but 3 vaccines which we can or which we should ideally is herpes and pneumococcal and flu vaccine. These are the 3 vaccines which cost comes to around 15,000. Or if we go for all vaccines, the cost exceeds 60,000 rupees, and it's a big burden on the patient with diabetes. So we recommend at least 3 vaccines. But at the moment, if you say all the patients are vaccinated, I admit they are not, but ideally yes.
So the other question is about thromboembolism prophylaxis. What is the status? Jonathan, what do you do in your practice for thromboembolism prophylaxis? Which patients receive it? How long do you give that? What are the side effects which you have noted? Can you just dwell on that part?
Yeah.
And I would also
Yeah,
ask we need to talk about it.
Yeah, well, I think thromboembolic prophylaxis is important, particularly in the hospitalized patients. So if we have somebody, for example, with acute severe UC, they all get thromboembolic prophylaxis. And we tend to continue prophylaxis until we've had control of their disease, because we know that they're at increased risk of this. And if they're very high risk, we'll continue it beyond the hospitalization until we have control of the disease. But I think it's very important to give prophylaxis in any of these high risk patients.
Vineet, you want to talk about that?
Yeah,
What is your practice?
in all acute severe ulcerative colitis patients, we give thromboprophylaxis. All patients undergoing surgery, we give thromboprophylaxis. Patients who are hospitalized, again, if it's a severe disease, Crohn's disease, we would like to give thromboprophylaxis. So, and we have seen that in such settings, if you don't end up giving thromboprophylaxis, patients do develop thrombosis or some deep vein thrombosis, etc.
So is it oral drugs or is it Clexane or what is it?
Since most of these patients are admitted patients, so we give them low molecular weight heparin. We do not follow that policy of giving them thromboprophylaxis for 3 months after discharge. So we do not put them on dox or something like that. And whenever high dose tofacitinib is given, nowadays it is being given in patients with the acute severe ulcerative colitis. It is very, very important to give thromboprophylaxis in that setting.
Manish, can I,
yes,
sorry,
sure.
can I just, yeah, actually, in our part, we see a lot of patients with, many patients with severe ulcerative colitis. And I want to emphasize that thrombosis is a real side effect, what you see in practice. We maybe 1 or 2% of a patient with the indoor patient, they actually get thrombosis. And we put them on low molecular weight heparin. And if a patient actually has thrombosis, then we change over to DOACs. Then they continue.
And
But
they continue for how long?
prophylaxis, sorry. I mean, it's if a patient, if IBD is the only risk factor, then we give at least for 3 to 6 months. If there is another risk factor for thrombosis, for DVT, then they are on lifelong. DOACs.
Vineet, you two more points. What you introduced us to concept of adding immunomodulators where you're using Vido or UTC. We have been doing that for anti-TNF drugs all along. Now, is the advantage compared to the side effects good enough for us to make it a practice routinely to add immunomodulators? Number one. And number two, let me just complete that. You presented the nice data of 3 arms and that if you are stopping, you stop immunomodulators rather than anti-TNF drugs. But in practice, in our scenario, when people are paying out of their pocket, we invariably end up stopping biologics and continue with immunomodulators.
So the first thing, sir, in Crohn's disease patients, if they're on vedolizumab or ustekinumab, then in those cases, if they're not responding to therapy, then one of the things which are tricks can be that if you add azathioprine, probably you can capture the response. Now, a recent study came out known as the Interpret study, which was for vedolizumab in ulcerative colitis, where what was done with the patients with ulcerative colitis, if they were not responding to vedolizumab, then the dose was given maintenance dose was given every 4 weeks instead of 8 weeks, the way we give for infliximab, 300 milligrams every 4 weeks or 600 milligram every 4 weeks, but it was not found to be used. Second thing is that what I showed in that study is the conclusion for the Western world was that you should stop azathioprine. But if you look at points to ponder, we find that 2/3 of the patient did not relapse, they had a drug holiday. They also had an economic boom in the sense that they need not buy infliximab. At the same time, 90% of them were able to capture the response. So clearly, in our setting, you may think about stopping infliximab and continuing with azathioprine. There's a nice study done by Dr. Sood, also known as a miracle study, where in ulcerative colitis, they stopped infliximab after 3 doses and continued on azathioprine, and it was seen that it was a good miracle.
Ajit continues to do miracles all the time. Not surprising. Jonathan, there are pediatricians around and they want to have a word from you about how to manage a pediatric IBD and what are the special issues related with pediatric IBD.
Yeah, well, I think, one of the things to realize is that early IBD is increasing in incidence now. globally. And so, treating these patients early is critical. One of the problems here in the United States is that, most of the drugs that we all use for adults is not approved in pediatrics. So my pediatric colleagues tend to be very aggressive with the anti-TNF therapies. Interestingly, and of course, I don't treat pediatrics, but interestingly, they tend to use monotherapy in the pediatric population and aren't using as much combination therapy as we do. But my recommendation is that if you are going to use monotherapy anti-TNF, that's where you really want to do proactive therapeutic drug monitoring, because if they're going to develop antibodies, they usually are going to develop them in the first 3 months, and it's usually because of low drug levels. So in those patients who you're going to use anti-TNF therapy as monotherapy, it's really important to check drug levels. We try to check at week 10 before the third infusion, and we like that drug level to be between 15 and 20, so higher than maintenance. But I think they tend to start with anti-TNFs. They don't use as much combination therapy. But if the patient doesn't respond or develops antibodies, then they'll go on to vedolizumab or ustekinumab, although, again, they're not approved for the pediatric population.
Mahesh, we are just coming to the end of that. You have any more questions? I have few questions.
Last question to Vineet. How do we know it's a superficial ulcer or a deep ulcer? Is it just a visual impression, or in a plus minus situation, you want to do a scan to find out the wall thickness at that area?
Yeah, so just for superficial ulcer, there were definitions which have been laid down, but they have not been validated. One is that whether they are more than, one is the breadth of the ulcer, the other is the depth of the ulcer. So if the ulcer has less than 5 millimeters, then you would say it's a superficial ulcer. Secondly, obviously, the depth of the ulcer. If there is no depth, you would do that. You would do scanning only if it is a deep ulcer or if a superficial ulcer has a major symptom. Then you would like to do scanning, and that to see for long segmented.
TSC, back to you.
Yeah, Mahesh, you did a wonderful job, and Ajit, you moderated both of you well. And the speakers, I have few questions from the pressing question they wanted to ask. Randir Sood has asked is, when do you suspect malignancy in Crohn's? Do you have that, or in ulcerative colitis? Or what are the high risk factors for malignancy? Quick answer so that we will take up another few questions. Then we'll go back to the very interesting session, chit-chat session, to know more about our faculty. Okay, Vineet,
So
malignancy in Crohn's.
Malignancy occurs if it is Crohn's colitis, it occurs as commonly as in ulcerative colitis if more than 1/3 of the colon is involved. Secondly, in Crohn's disease, you see lymphomas and adenocarcinomas of the small bowel also. Then you see anal, if there's perianal fistulizing disease, you see anal cancers, or even if there is an ileostomy form, you can find cancers out there. So in Crohn's disease, again, you do look for cancers in all these situations.
A question to Professor Jonathan. Malignancy in ulcerative colitis, when do you start suspecting? What are the high risk factors?
Yeah, so in ulcerative colitis, which we see malignancy more often than Crohn's overall, in patients who have anything beyond proctitis, we worry about the development of malignancy, usually after 8 to 10 years of the disease. And also, the biggest risk factor we worry about is someone who has ulcerative colitis and PSC, primary sclerosing cholangitis, high risk factors there. And then anyone with ulcerative colitis who develops a stricture, you have to worry about a malignancy. And so we start surveillance after 8 to 10 years of disease.
When do you suspect invisible dysplasia? Nowadays, we talk about invisible dysplasia. The question from delegate asked, and how do you take biopsy if it is not visible endoscopically?
Yes. So if we're worried about invisible dysplasia, we'll use either dye-based chromoendoscopy or digital NBI in our patients. But the invisible dysplasia, if they have visible polyp, we remove the polyp and we take biopsies in other areas to make sure there's no dysplasia. But if you get invisible dysplasia, meaning the mucosa looks normal, and they have evidence of multifocal dysplasia, we worry about that. And to follow that up, we do, again, the chromoendoscopy. But in most of our cases, if they have multifocal dysplasia, particularly if it's high grade, then we recommend a colectomy for that. But you have to be very careful.
We have many more questions. My request is I'll send it to you, both Vineet and Professor Jonathan, Ajit Sood, of course, to Mahesh, some endoscopy question. So you'll be kind enough to answer to the delegates. So don't feel bad, my delegate, that so many people done. And I'm glad to inform you, over 445 people have registered for this webinar. It's a great success because of all of you that are coming. Ajit, the last question is, growing children, when you have a florid Crohn's disease, where biologicals are unavailable, unaffordable, and you can't give the steroid because the stunting of the growth. So how do you manage such cases?
In Crohn's, I think diet plays a more important role than what diet plays in adults. So we need to be very particular about diet. If we have to guide them about the healthy diet, but then we can make use of diet as a nutrition as a EEN, exclusive enteral nutrition. Some of the refractory patients who don't even respond to the biologics may actually respond to EEN. So we should continue guiding them about the diet and the PEN. Otherwise, if biologics are not possible or not in the reach of a person, then we have no choice but to use immunosuppressive agents like azathioprine or with 5-AS.
I thought I'll refer it to you.
Ajit, what about short courses of steroids? I mean, sometimes giving a 3 to 4 weeks of steroid may be good enough to control the disease.
Yes, but never for maintenance. I mean, even budesonide, if we consider budesonide, even that should not be used for maintenance.
Sometimes what we do is, like, people who really cannot afford anything, then we give them betamethasone 5 milligram on Saturday and betamethasone 5 milligram on Sunday, 2 days a week as maintenance. So that really does not cause HP axis suppression, and this is something we have picked up from the dermatology people.
Okay, give a short term, as Mahesh said, and after that you have to concentrate on nutrition, and if the biologicals are not affordable. This is what. And the last question is terminal ileal stricture. You have take biopsies, and it is non-conclusive. How will you go ahead about it? The report comes as terminal ileitis. Dr. Vineet?
So I think I talked about it, that one is the non-specific and specific. If it is a stricture, obviously there's specific etiology. So you need to do the workup for TB versus Crohn's disease, do a CT chest out here, do a Montu out here, and take deeper biopsies to find out what is happening. The CT look for necrotic lymph nodes. And if there's an isolated stricture, then you have two choices. One is straight away go for surgery, because surgery would be diagnostic and therapeutic out there. You could get the definite etiology outside and also take care of the stricture out here if it is a short surgery.
I think you discussed this. I think we have come to the end of this session now. And what we are going to have a very interesting session now. We're going to know more about the journey of our faculty. So all four of you under scanner now. Professor Jonah.
All 5 of us. Five of us.
Who is the fifth one?
If you can't leave yourself.
Okay, Jonathan and Vineet, Mahesh and Ajit. First, let me start with Jonathan. So I saw in your biodata, this is going to be a very, very interesting. That is going to more information to our delegates, and it will be very inspiring to our delegates. I went through Professor Jonathan biodata. It was very, very impressive. I would like to know more about cum laude and 5 beta kappa you have written. Everything looked Greek to me. What is it about? Briefly, I request all of you make a very brief answer so that we can take up as many questions as possible, and our delegates are looking forward to listen to you. Yes.
Thank you. Well, the cum laude is something that we get in college. There's a magna cum laude, summa cum laude, and they're collectively known as Latin honors. And basically, it's not based on any standard score, but it's just a recognition of academic achievement. That's what the cum laudes are, and you get that in college. The other one is Phi Beta Kappa, which is a society, and it's a society that celebrates excellence in the liberal arts and the sciences, and it actually champions freedom of thought. So it's a prestigious society that reflects academic achievement.
Congratulations. We are very proud to be
Thank you.
to having you as the luminary from this college. And what I
I
want
will
to
also add 17 US presidents have had Phi Beta Kappa. So
oh, that is an information too.
much more famous than me.
Can we, any one of us apply and become now?
No, you can't. But Jonathan has a scope. But Jonathan can become the president of USA. That
Yeah, he can become the president of USA.
That's great.
That's a nice one.
Yeah, pointed question,
Wait.
brief, and how did you develop interest in IBD? Professor Jonathan?
Well, you know, so very interesting. When I was a gastroenterology fellow training in San Antonio, Texas, I did not see any inflammatory bowel disease. It wasn't very common in the Mexican population. So when I joined Mayo Clinic, I actually started in motility and worked with Michael Camilleri quite a bit. But in my second year of practice, I got involved with the Crohn's and Colitis Foundation. And because of my involvement in the Crohn's and Colitis Foundation and volunteering for them, I became very interested in inflammatory
the
bowel disease.
foundation laid foundation for you in developing interest.
Exactly.
What about Vineet? You developed mostly the Indian gastroenterology will be interested in endoscopy. How did you develop interest in IBD?
Because I think I developed interest in IBD. One is that because at AIMS I had to work in luminal gastroenterology. That was a slot for me. So
It is by chance or by choice then?
At the same time, I wanted to have interest in GI immunology and gut microbiome. And I thought it was a great intersection for working in basic sciences as well as clinical sciences. I do enjoy working in basic sciences.
That is the basic immunology and basic sciences interest that took you to IBD. Okay, right. What about Ajit Sood?
My professor was a gastroenterologist and he used to do sigmoidoscopies. And whenever he used to do sigmoidoscopies of young girls, he'll say, "You people get out." He used to turn us out. So I became so curious that why should we be doing sigmoidoscopies? So I thought I must pursue IBD and to see what is happening.
Oh, right. Because of sigmoid. How did you develop interest in endoscopy, Mahesh?
I think my early days were in PGI Chandigarh. And at that time, the endoscopy was developing, and Dr. J.B. Dilavri was in the helm of affair. I think seeing him, his flamboyance while performing endoscopy and the importance he was getting, I think that may be one of the beginning for my becoming an endoscopist as a priority. But I like to be called a general gastroenterologist more than anything else. I think I have interest in all the specialties. You can call me a graduate and not a super graduate. But my interest is in the general gastroenterology.
You are interested in everything, but more so in endoscopy.
No, I would say I'm interested. Yes, you can say that, but
probably this webinar will become interest in IBD.
No, I do have interest in IBD. I think I treat a lot of IBD patients. At least 10 to 15% of my OPD population is from IBD.
Okay. So the institution made you something.
Yeah.
And who is your famous sports specialty, Jonathan?
Well, that one I liked. Well, you know, coming from Phoenix, we have the Phoenix Suns, and Charles Barkley was always one of our great sports heroes in Arizona. So for football, for basketball, it's Charles Barkley. For golf, it's Tiger Woods.
Okay, very good. How did you develop interest in marathon, Dr. Vineet?
I think I must be fat, overweight, so I thought that I had to cut it down. So I started running.
I never seen you overweight any time in my last 2 decades.
He's
overweight with knowledge.
He's weighty, not overweight.
Okay. So still you are running marathon?
Half marathons.
Half marathon.
21 kilometers.
Apart from gastroenterology, what is your interest, Mahesh?
I think the leadership and organization. I think that's something which I find myself passionate. Sometimes I feel that it's a unnecessary passion, but organizing conference, having a leadership position.
That's why you become the president of ISG, SGI, and so many conferences you organize. The leadership.
I'm so happy that after seeing me as the governor of ACG, it interested you and you became the governor. So I'm so happy that people like you are entering into the governorship of ACG. And I'm sure with your working and your doing these webinars, there will be more and more interest in ACG in the coming years.
Very good. Congratulations. And Ajit, what is your areas of interest apart from IBD and the clinical work?
I follow sports. I really appreciate this chess prodigy from your city. And Gukesh has done a wonderful job. He's going
Okay,
to
this is one of the youngest, not the one of the
yeah.
youngest,
He's the youngest by a few. I mean, he
17
missed it
years.
by 17 or 20 days. I mean, his father is a doctor and mother is also a doctor. I mean, I really appreciate, admire his.
Ah.
And my second thing I enjoy doing is sit with friends, just do useless talk, chit chat with them, and
So,
whenever get time to sleep.
okay, how do you de-stress, Professor Jonathan, when you are really in the height of your stressful work and I think how do you cool down?
Yeah. Well, I have to say that I for the last 2 years, I've been the medical director at Mayo for the Office of Joy and Wellbeing. And so we have a well-being practice that I do every morning, which is a practice of gratitude, a practice of listening to a happiness podcast for 5 minutes, a practice of reading a book on well-being for 5 minutes, and then doing stretching. I do that every morning. This morning I had to wake up at 3:30 to do my practice, but I did it anyway. So I do that, and then I love the outdoors. So hiking,
Yeah, I saw your
backpacking.
mail at 4 o'clock, 4 a.m. I really
Yeah,
appreciate
yeah.
how I think you are more committed. That is maybe the reason. And what is the famous quotation you like, Vineet?
Quotation.
No.
Yeah. Okay. Means I think
Quotes.
happiness comes from within. You don't need to depend on anything or anybody for happiness.
And this is a simple thing. Okay. What about you, Magesh? Any quotation?
Quotation for me is that it's your attitude which decides your ultimate height or the aptitude. It's your attitude. I think attitude to the life is most important.
Oh, your aptitude decides your attitude. Attitude decides your altitude. Okay. Like that. What about Ajit?
I tell my wife often that happiness is homemade.
Uh-huh. I know your wife very well, so I will ask her, check whether what you are telling is right or not. Okay. So now all you have been achievers, all of you. How do you get a protected time for the research and publication? Start from Jonathan.
Yeah, it's not easy to get protected time, even at Mayo Clinic. But I was fortunate. I got involved early on with administrative duties like the Office of Mayo Clinic Experience or the Clinical Practice Committee, and that gave me some time. So I was able to use administrative time. Sometimes from drug trials, I'd get a little bit of research time. And then the rest of the time was evening and weekends.
What about Vineet, followed by Mahesh?
I think the thing about protected time is a myth. You get protected time only on airports in long flights. Otherwise,
That's the reason why you travel very frequently. Eh?
Always on the wheels.
Okay. And what about you, Ajit and Mahesh?
I have a team. Sorry, Mahesh, please.
So I would only say that when I left PGI Chandigarh in 1996, which is a long journey, 28 years back, the only thing which was bothering me was that in the private sector, which I'll be able to do the research and education. And I think I'm not regretted one bit that in these 26 years or 28 years, I've been able to do justice to both education and research. We don't do basic research like Vineet has the ability and the resources, but yet we are able to publish. So I was just looking at the number of publications in 2023, and we could publish 41 papers from my department. And that's because of the group, which Ajit was just started to saying that. You have to choose your team very well. And if you have a team which is as passionate as you are, then the job is 90% done. At my level of journey, I just have to go through the reviews written by them or the papers written by them and just give a final touch to that. And that's all I'm doing now. And I'm happy to.
So for you, teamwork, for you, drug trial and other areas, administration work, for you, journey work. What about Ajit? What does it work for you?
We have a good team and we have different responsibilities. They work, I take credit. So
I
this
thought
is
you were not in
understanding.
WhatsApp and wasting time, so I thought you get the time like that. Okay. Then what is any idea?
Can I ask Vineet one question?
Yeah.
Vineet,
Yes, sir.
you think WhatsApp is a waste of time?
No, I don't say it's a waste of time. I will not be able to keep up with it in the sense.
Oh, that's a reason. Okay, okay. I think Ajit is not in also in the WhatsApp.
Whenever if
Uh,
ever I want to see WhatsApp, I have to go to my wife's phone, pick it up, and I can
So,
see.
does it mean that the IBD people do not like WhatsApp? Can we conclude? Randomized study.
I think both of you very difficult to contact them. Anyhow, what is the path for the clinician? Any path there available for the clinician to get a Nobel Prize? Professor Jonathan. My son is also there listening to me now.
Yeah, well, I think I want to emphasize what Ajit and Mahesh said about the team. You have to build a team of people who are going to work together. And then you really have to stay focused and committed to a certain goal. And that's not so easy to do. But I think building a team and staying focused on what you're working on and committed to that is critical.
Now, Mahesh and Vineet, and if you are now choosing what is the ideal path for a clinician to start with?
So I think nothing is ideal. You need to decide what you want to be doing in your life, what keeps you happy. I was talking to Vineet a couple of weeks back, and I said, Vineet, will you leave AIMS and join a private practice? He says, I'm happy with what I'm doing. So I think it all depends on, and we started with this, is what keeps you happy. You choose your path. So I have to decide when I finish my fellowship as to where do I see myself after 10 years. And if I see myself after 10 years in an institute like All India Institute or PGI, then I have to follow that path. So I think the path has to be decided by self and it cannot be dictated by anybody. So
Okay, one word.
I had a combination that I worked at PGI Chandigarh for almost 13 years and then moved to the private sector. So I think it's all your judgment, all your decisions, what you take. And they cannot
So
be
you have to
path.
decide what you want in life. That may be changing every 5 years also, but accordingly you remain happy. And one word answer, what is your mantra for work-life balance? Starting from Ajit.
As I said that I have a team. I mean, I work
You
and
started with the wrong person. He finishes his work at 2 a.m. in the morning.
That's the
So
reason that
there cannot
I
be
wanted to ask
any
deliberately.
mantra for him.
How do you mantra for work-life balance?
if you let me sleep, I'll sleep right now. So,
Okay.
so it's a combination of work and sleep together.
Okay, Professor Jonathan, work-life.
Yeah, well, I would say what I like to say is that the happiest people don't have the best of everything. They just make the best of everything. So it's how you approach life and live in the moment.
Okay, very good. Mahesh?
I would only say that if you really want to have a work-life balance, you need to develop a team. I used to work till 12 o'clock, 1 a.m. Till about 20 years back. Now I am back home. I'm back home. I'm in home at this moment, while some of you are still at the workplace. So I think it's developing the team, having confidence in your team that they will be taking good care of
So
your
the team
patients.
makes,
So I think
you
a
are the
team makes a
winner
big
if you are a
difference.
team member.
Yeah.
And what about
Absolutely.
Vineet last? Vineet?
So
Work-life balance. You are already there balancing because you are in an academic institution. You already have a team. That's the reason why you don't want to leave that. Now coming to the final thing about the vote of thanks. I thank you very much, Professor Jonathan, Vineet, and Ajit, and Magesh, and my fellow members and ambassadors for this wonderful opportunity, and our academy partner, Sir Jairaj, and all the members who have gathered from all over the world and all the delegates. I must really be thankful for giving this opportunity, and we will meet next month on the topic will be on acute severe pancreatitis. Very, very exciting topic, and we have Dr. Vivek Kaul coming here. They will be on the webinar, and we have Dr. Pramod Gar also going to give the talk. Now, may I request Dr. Gokul. I think all the thing over chit chat session. Now coming to the vote of thanks, I will hand over the mic to my colleague Dr. BJ Gokul. He has been instrumental, what Mahesh was telling, in creating a team at MedIndia. So I'm able to do all this academic work and relax a little bit. And he has got a lot of credentials, gold medals, and various awards to his credit. Dr. Gokul, please.
Thank you, sir, for the kind words. A very good evening to all of you from Chennai. I thank every one of you for this wonderful evening today. I thank my chief, Dr. TSC, for mooting this idea of international webinars and inviting stalwarts in the field of gastroenterology as faculty and getting this program and the future programs accredited by the ACG. On behalf of MedIndia Hospitals and Academy, I would like to offer my sincere thanks to Professor Jonathan Lighton for having delivered the inaugural address and for accepting our invitation to deliver the MedIndia oration. Thank you very much, sir.
Thank
I
you.
also thank
You're
our
welcome.
co-speaker, Professor Vineet Ahuja, for accepting our invitation to deliver the lecture on choosing the appropriate drugs in Crohn's disease. I thank both speakers for their educative lectures covering various aspects of inflammatory bowel disease. The chit-chat session was really very interesting part. It was truly inspiring to listen to all the doyens. I thank the moderators, Dr. Mahesh Goenka and Dr. Ajit Sood for the excellent moderation and also for making this the question and answer session very interesting and interactive. I thank my colleagues, Dr. Prasad, Dr. Satyamurthy, Dr. Raja Yogesh, and also the technical and the admin staff here, Mr. Sivanandam, Mr. Sashidharan, Ms. Sasikala, and Mrs. Selvi for their inputs and support. I thank our academic partners, the Microlab Academy, and Mr. Jayaraj for the sponsorship. Not the least, I'd like to thank all the delegates for logging in today. We had close to 2,500 registration from all over the world. That shows the enthusiasm. Special thanks to all the ACG members who acted as ambassadors spreading the message of this webinar in their respective regions. We thank the press for the coverage of the function. And before concluding, I would like to remind you about our upcoming webinar scheduled for 29th of May on pancreatitis. And looking forward to seeing you all again. And till then, it is goodbye from all of us at MedIndia Hospitals. Thank you.
Bye.
Thank you very much.
Thank you.
Bye-bye.
Thank you.
Thank you very much.
Thank you.
Thank you and bye-bye.
Chandrasekhar. Thank you, Dr. Sood. Thank you.
Thank you, everyone. Bye-bye.